Can you see it?
Yes.
Shall we wait for the other student? Can know they used to be 50, 51? ليث موجود ولا لا؟ هو الليدر صح؟ اوكي ابد خذ راحتك. I can wait. Okay. Asymptomatic, we explained it earlier, nothing to do. As I said, more than 50% of patients with gallstones are asymptomatic. Just leave them alone, don't do anything. Prophylactic cholecystectomy is indicated in certain scenarios, like the one I mentioned, which is the sickle cell patients, those with polyp with a stone. If you have a patient with a stone and polyp, it's better to do a cholecystectomy, because these polyp can be pre-malignant with the presence of gallstones, because the ongoing scarring, again, fibrosis and healing and so on, these the ongoing healing process can cause scarring of the gallbladder, and this is one of the contributing factor to gallbladder malignancies. You don't want to be dealing with a polyp as well as a gallstone. So, but in completely asymptomatic with no sickle cell disease, no polyps, stone is not bigger than 1 centimeter, 2 centimeter, don't touch them. If the stone is too big, even if he's asymptomatic, I would offer this patient a prophylactic cholecystectomy just in case, because it turns out that big stones are a risk factor. Again, not a direct cause, but a risk factor of gallbladder malignancy. Okay. Biliary colic, I think I've explained it. I've explained all the scenarios of these stones. Biliary colic, as we said, the stone blocks for transient blockage, then it goes back. You can just read this because I'm sure I've mentioned all of it. Acute cholecystitis, as I mentioned, the blockage of the infundibulum or the neck of the gallbladder persists, and the patient comes with he will be more sick than the biliary colic. You will have the high WBC, you have the low-grade fever, and so on. Clinical presentation, we mentioned almost all of these things. Clinical presentation, we've talked about it. One thing is Merizi syndrome, and Merizi, actually, it's not your level, but since it's written here, let me just explain what Merizi is, basically. Yeah, I don't expect a medical student to know Merizi syndrome. But anyways, so let's say that you have a stone stuck in the neck or in the infundibulum of the gallbladder, okay? And the stone is too big that because of the size of the stone, and this purely depends on the size of the stone. So if the stone is big enough to cause an obstruction, an external, I will not say obstruction, let's call it an external compression of the common hepatic duct. So there's no obstruction here whatsoever, but the stone is stuck in the cystic duct or in the infundibulum, but the stone is too big that it exerts an external pressure into the common hepatic duct. That pressure can cause an obstructive jaundice because it blocks this area. That's basically Merizi syndrome. And how do you know you're dealing with Merizi? If someone answers me this, I don't want to swear, but I'll give him very good extra marks. What will you see in the images? I need full detailed report. What would the radiologist tell you in the image? And please, guys, don't use ChatGPT. I know everyone is using AI nowadays, but come on.
Narrowing of the duct,
Which duct?
the common bile duct and the hepatic.
No. Nope. Common bile duct has nothing to do with this.
It will be narrowing of both the cystic duct and the common hepatic duct.
The distal?
The cystic duct and the
Proximal,
common
proximal,
hepatic.
proximal.
Okay, but tell me what would the report says?
Proximal bile duct dilation
Uh-huh.
or compression of the common hepatic duct
Uh-huh.
or yeah,
And
because you said the stone impacted, so the stone would show in the infundibulum or the cystic duct.
Okay.
Sometimes
طبعاً.
مثل الgallbladder اللي حكينا قبل a fistula might happen.
Besides that, what else?
positive sonographic Murphy's.
It can happen, but what else? I need a major thing that I can say, oh, this is Mirizi. This is not distal bile duct obstruction.
Let compress on the surface.
What?
Will it compress the portal vein?
Okay, we have the compression, but what else?
Dilated intrahepatic duct.
Dilated intrahepatic, we said that. But what else? How can you differentiate between Mirizi and obstruction here? This one will also cause dilatation of the intrahepatic.
The common bile duct will not be distended.
The pancreas can drain freely.
Wait, who
in
said this?
Mirizi.
Selma?
Yes.
Excellent. Tala, you did well as well. Selma, what she mentioned is actually the cardinal sign to diagnose a Mirizi syndrome. The radiologist will basically tell you your CBD is normal, yet you have dilated biliary duct. Sometimes they don't see the stone, by the way. Whatever you mentioned is excellent. And yes, this is the cause. But the radiologist will only tell you two things. He will tell you, I have a dilated intrahepatic system, yet I have a normal CBD. So by that, you know your obstruction is above. It's at this level. It can be one of two, by the way. It's not always Mirizi. It can be malignancy here, cholangiocarcinoma. It can be a stricture here as well. But if you see that stone, it's a Mirizi syndrome. Make sense? By the way, you all did good, wallah. Whoever answered, you all had different insight, but you helped. Thank you all. We'll go next. Mirizi واضح. Does everyone understand Mirizi syndrome? Excellent. We explained all of these findings in ultrasound, differential diagnosis. Okay, so whenever you have, this is pure medicine. You don't diagnose patient based on one symptoms. You should always have differential diagnosis, and you rule these things based on your history taking, which is the basic understanding of medicine. That you have to rule out differentials to reach the diagnosis with the help of labs and radiology. I mentioned this, the venous outflow, lymphatics, mucosal edema, hypervascular, we mentioned it. Pathology, we explained the bacterial infection, management. So basically, this is not being applied anymore. I know you still have them in your textbook. I still have it in my own textbook in HPB, but this is not being applied anymore, meaning that if patient, what this one says, it says if the patient presents within the first 3 days, that you can go for immediate cholecystectomy. But if the patient present with after 3 days, then you go with conservative and you do an elective in 6 to 12 weeks. This is not true. We don't do this anymore. All patients get cholecystectomy. Everyone gets a cholecystectomy. Okay. Complications, nothing so interesting about this. It's all the same. High drops. Yes. Basically, if you open the gallbladder, you'll see clear mucus. It has nothing to do with the cholecystitis itself, but it's nothing impressive about the high drops. I would care more about the emphysematous, which is more toxic, more septic. Patient will die because of it, and it can rupture the gallbladder. empyema as well. So you'll have it's an infected bile within the gallbladder. And these patients, yes, they're more toxic than patients with just simple acute coli. Gallbladder perforation, nothing impressive about this. You understand the concept of the perforation. You understand the concept of the fistulas can happen anywhere. You can have in very rare scenario that the fistula happens between the gallbladder and the skin, and we call it cutaneous fistula. And as I mentioned, the fundus is the most common area. Why? Because it's the area where the gallbladder can pedunculated with the pressure and with the gravity. The rest of the gallbladder is attached to the liver, but the fundus is not attached to anything. So that's the most common area of the perforation. This is actually a good one. If I write a new question, I might write this one. It tells me if people understand the anatomy of the gallbladder and which sides of the gallbladder are attached and which side is free, not attached to anything. Gallstone ileus, we explained it. We talked about it. Biopsy chronic, nothing impressive. So yeah, this is one other topic that's common to see in the surgical practice is these primary CBD stones. And to say that this patient has a primary stone, gallbladder should not be there, or at least the gallbladder, the cholecystectomy has to have been done 2 years prior to this presentation. Because any CBD stone after cholecystectomy, within the first 2 years after cholecystectomy, we call it remnant stone. The stone, some stones get stuck into the stump of the cystic duct, and within the period of 2 years, they can pass into the common bile duct. But if the cholecystectomy has been more than 2 years ago, and the patient present with obstructive jaundice and you find a stone in the CBD, we call this primary CBD stone. And why does this matter? Because if it's a primary CBD stone, you need to look for the underlying cause, why the patient developed a stone within the CBD. And usually the causes are like liver flukes, parasites, strictures, primary sclerosing cholangitis, malignancies. So that's why we focus on primary CBD stones, because it has a lot of differentials compared to just a secondary stone that's from the gallbladder. Make sense?
Yes, doctor.
Okay. This is the secondary, the retained stone, as I mentioned. These stones usually came from the gallbladder, but you did your cholecystectomy, or even before doing the cholecystectomy, any stones with the gallbladder still in place, it's a secondary stone. But the retained stone is when the cholecystectomy has been done in less than 2 years. Sorry, just give me a second, guys, okay? ايوه هلا شباب. Sorry. So you understand the concept of retained CBD stone?
Yes, doctor.
Excellent. Okay, so this is what we just mentioned. Nothing special about this. Jaundice, we talked about it. I'm sorry. Pre-hepatic, hepatic, and post-hepatic. This is medical. This is not surgical. I'll delete this slide in next group presentation. Jaundice, we talked about it. You can just see, entertain yourself and read about this, but there's nothing to explain. And the management is almost applied to all of them in terms of the. So don't apply the prophylactic antibiotic for jaundice. This is not correct. Okay, it's for cholangitis. Jaundice patient, they don't get antibiotics. You look for the underlying cause. We talked about, and take this out. It's PTBD, not PTC. Pus under pressure infection. We talked about this. We talked about cholangitis, the management. Okay, this is the Charcot triad. It's good to know it. You guys like to rub it in my face in the exam, the pentad and the triad, but okay, say it in the exam as well. Basically, any cholangitis, the patient will be jaundiced, febrile, and he will have symptoms of biliary colic. But don't push it into my face for the exam. All June. When I tell you cholangitis, you tell me Charcot triad. Just a second, guys. Okay. We talked about the management of cholangitis. Basic lab works, nothing special, same management as everyone else. We talked about the liver abscesses in terms of cholangitis. The liver cirrhosis, yes, and we see this, I wouldn't say with cholangitis per se, not every cholangitis. We see it more with the oriental cholangiohepatitis, which is a different entity. These patients, it's common among the Asians. They have strictures within the biliary system that can cause a repetitive cholangitis, and eventually it causes a liver abscess and liver cirrhosis. It's a different disease called oriental cholangiohepatitis, and I think they changed its name because it sounds racist, the oriental part. So I don't know what they call it nowadays, but in our old textbooks, it used to be called oriental cholangiohepatitis. Maybe now they call it just cholangiohepatitis. Anyways. Cholecystectomy, nothing special, just basically surgical. It's good to know the complication of cholecystectomy, but I wouldn't ask you in the exam about how to do a cholecystectomy. Again, it's a level of surgical resident, not medical students. What do you need to understand from the post-cholecystectomy syndrome is just keep in mind that the gallbladder is not there anymore. The bile will flow freely into the biliary system, then into the bowel. In the first 2 weeks, the bile will not be secreted as much as it used to. So the body will take time with the negative feedback that happens with the enterohepatic hepatic circulation between the small bowel and the bile return. We call it the enterohepatic hepatic feedback. So with time, the liver will make the right amount of bile to absorb the fat. But for the first 2 weeks, these patients might have diarrhea due to the fat not being absorbed, as the bile is not being secreted in a good amount. You might as well have the one of the important thing is the retained stone, because this is what happens with the some of these scenarios that the patient develops obstructive jaundice secondary to a retained gallbladder stones. This is bullshit. So I'm sorry, but you don't have to know the cholecystomy tube and the. No, this is wrong. Sorry, just a second. Delete. How do I delete this? There is no such thing. Okay, I don't know how to delete. Oh, okay. There's no lithotripsy when it comes to and also medical dissolution. Sorry, whoever made this, I've never been to HPB. So yeah, cholecystostomy tube, yes, it's one of the options. If your patient is not fit to go for surgery and has cholecystitis, and patient is very sick and the surgery carries a very high mortality, then another way to drain the gallbladder is through the cholecystostomy tube. It follows the same concept as the PTBD, but instead of going into the liver, you aim for the gallbladder immediately and you place a tube to deflate that gallbladder because it's severely distended and it might rupture. And the way to avoid these complications is just to place a cholecystostomy tube to drain that bile and make sure that the gallbladder deflates and no more extension, no more rupture if the gallbladder happens. Intraoperative cholangiogram is another maneuver that we do intraoperatively if we believe that a stone has gone into the biliary system. When we do our cholecystectomy, basically we use the cystic duct to insert a guide wire, then we inject contrast to delineate the anatomy of the bile duct with the help of an X-ray intraoperatively, and it shows us if there's a good filling or not. Acalculous cholecystitis, as I mentioned, this happens basically in severely ill patient in the ICU on TPN, intubated. Basically, you have a cholecystitis without a stone, and it's more common in the ICU setting than you never see it in the clinic or in the emergency. Usually, it's in the severely sick patient, and it's all due to bacterial translocation rather than an obstruction that happens in the gallbladder itself. Biliary dyskinesia and sphincter of OD. This is honestly, first of all, it's medical. Second of all, it's not that common. Cholestrosis and polyps and adenoma, it's all within the gallbladder wall. The only way to differentiate between these two is by ultrasound. The ultrasound will show you a shadow. It's a stone. If it doesn't show a shadow, it's just a cholesterol polyp. Adenomyomatosis is another kind of polyp, and the only way to differentiate between them and the cholesterol polyps is the number and the pedunculation, whether they're flat or pedunculated. Again, you're not going to need it much. Choledochal cysts, I'm sorry, this will take me 1 hour to explain choledochal cyst because it's a very big topic. It's common among pediatrics, but it has a lot of subtypes. It has different management. What you need to know, it's a pre-malignant condition. It's congenital. The people are born with it. You don't develop it out of the sudden. And it has 5 different types, 5 different locations, and 5 different managements. They're at risk of developing cholangiocarcinoma. Okay, now لسه مصحصحين I go into surgical site infection.
Yes, Dr. Rahim.
والله I doubt it بس okay.
حضرتك عايز الصراحة
سم
حضرتك عايز الصراحة
قولي الصراحة، أنا أحب الصراحة.
my brain is fried فيعني ما أظنش إن أنا أقدر أخد محاضرة تانية بس لو الوقت
No.
يسمح ممكن عادي.
Not you only. And my brain move fried. There's no brain anymore. But anyways, if I'll leave it to you guys. If you want to schedule it another time, or if you want me to do it now, it's up to you. Laith, it's your decision.
Doctor, can we schedule it a different time?
Please, 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 please.
It's up to you guys. As they said, I'm a servant of people, so I'm just here for you guys. Whatever you need, you want to reschedule it, you want to have it today. Yeah, أنا بالنسبة لي ترى I'm free almost every weekend. Weekdays after hours I'm free if I'm not on call. So just make sure if it's gonna be a weekday, we can do it after 4, after 5. It's gonna be, I would say 45 minutes to 1 hour. If I shut my mouth صراحة أنا مشكلة إني أتشعب. I go deep into the topics, but I'll try my best يعني to stay within the time limit. So Laith, I'll hear from you whenever you guys decide when to get the lecture, okay? Yeah, enjoy your weekend, everyone. Have fun.
يعطيك العافية.
يعطيك
الله يعافيك.
شكرا دكتور والله بجد شكرا على كل
You're
حاجة.
welcome.